Good morning, everyone. Thank you so much, Anneloes. Thank you for the invitation to the organizing committee. Already, we just have got started, and already it's a great session. Thank you, Imelda, for your great talk, and I want to expand a little bit on that future perspective. I fully agree that we shouldn't look back, we should look forward. Where is the field going? And after 20 years of work in Rotterdam and many other places, I think we have a lot to build on. So my name is Willem Gorter. I'm a professor of pediatric rehabilitation medicine in Utrecht, here in the Netherlands. And I also am connected to McMaster University in Hamilton, Ontario, Canada, where there is a research group. It's called CanChild, Center for Child with Disability Research, where I had the pleasure to work both as a clinician, as a researcher for 13 years. And CanChild is a center that really focuses on children and young people where they live, so at home, at school, and in the community. And that has helped me also to move beyond the direct care that I used to do as a clinician in pediatric rehabilitation medicine. Also, when you move countries, and we had a conversation at the start this morning, you also learn that things can be organized in a different way. And so this is great that we have an international platform here today, and I certainly hope we will learn a lot together. That brings me also to the title, Let's Make Transition Better, a very ambitious title, of course, and shaping positive future locally in our own setting, but also looking at what needs to happen at the national level and at the international level. So we have the great platform here today. And maybe I can summarize that long title in what Anneloes just said is less talk and more action. I'll come back to that. I included a conflict of interest disclosures slide. And as I told you, that I had the pleasure working with young children, but I sort of, and I'm old enough that I grew up with those young children. I start seeing them becoming a teenager and then helping them prepare for their moving out of the pediatric setting into adult healthcare. My background training as a rehabilitation specialist here in the Netherlands is both adult and pediatric training, so you have a little bit of context, but I really attached and working in the field of pediatric setting, so at the Willem Children's Hospital and the Princess Maxima Center for Pediatric Oncology now. Also having worked in Canada, and yet that other perspective is that I learned so much from my colleagues working with other chronic health conditions, both physical and mental health conditions, and seeing the similarities. There are more similarities than differences between the different diagnoses. I'll come back to that in a later. So I strongly feel that all these children and young people with some sort of healthcare need, a special healthcare need, because that brings them to our attention, need help, and we have to develop interventions that are not only working at the level of a group level or systematic review level, but in the end, it's the individual child or young person and family that needs to benefit from it. So it has to be carefully tailored to them. Even if it's working for the whole group, it can still be and has to be tailored. Timing is a very important thing because it can work at a certain point in time. I have had that experience that I sometimes tried an intervention and found out that that person was not, it was not at the right time. In all the principles, we say it has to be developmentally appropriate. And it has to be integrated. Yes, we can develop e-health tools and so forth, but still there is the human side to it. And if we give a tool, or whether it's a document or if it's an e-health, an app, and we give it to the young people, and we are not making the connection to our own services and the human side, I think we miss out on the key ingredient of success, which is the human factor. So it all starts with a conversation. I think we're all people, and it all starts with interactions. And during that transition process, there is a lot of interaction happening, actually, or it should be happening, and it has to be initiated by the healthcare provider or people in the setting that have the understanding that what is coming in the future. And a lot of families, as you know, and young people may have a sort of understanding of, oh yeah, I'm growing up and it might be different for me because of my chronic health condition, but don't realize that it takes time, real time, to actually work to get to that point that you are sort of ready, if you want to use that term, for transition. I heard, thank you, Annelies, for that introduction slide, because I was about to ask who is in the room, but now I know. Only I have one additional question, is if there are any people, young people or families with lived experience in the field of transition, in addition to professionals. They will be here at the afternoon. Excellent, excellent. I was assuming, but I was wrong, that most of us would be in the field of pediatrics as a core business. At least most of the literature is in the field of pediatrics. But I'm very happy and pleased to see that there are already so many people working in adult healthcare or adult care settings. And I think if you look at the bigger picture, growing up is sometimes hard to do for any adolescent, but for young people with chronic health conditions, it's even harder, because there are many other layers that brings to that growing up process. And I'm very pleased, and if we talk about the future, I want to zoom out with you, because we were talking about transition and the process, but leaving the pediatric health setting and moving into adult setting, becoming an adult. What is really the meaning of the word adolescence, is that basically we're talking about people like we all are from birth or even before birth into adulthood, and even with aging into older adulthood. And I'm very pleased that I came across this work by Neil Halfon from out of the States, California, who wrote quite almost 10 years ago about the life course health development, and also bringing that new perspective of an approach to healthcare and approach to see where we fit in with our transition process. And that's exactly somewhere between adolescence and adulthood. And why is that so challenging? Because I think there are not only the people are changing, so you're a teenager becoming an adult, but also there are a lot of changes in the environment. And that means that the person-environment interactions change a lot. And that makes it so complex. So if we think of that life course health approach, then already we have to think of a lifespan approach, which recognizes those transitions. And there are multiple transitions, not only in medical care, but also in other fields of and domains of functioning. It often requires a comprehensive care plan. If you will hear it from, I'm sure, from the youth and the families with lived experience, that yes, there are parts of it addressed, but from the perspectives of them, it's still challenging to bring it all together. And who is actually doing that? And what I've learned also from working with the ministry in the province of Ontario in Canada was that if you look at the bigger picture, then the diagnosis or the health condition is only one of many factors that determines outcome. Maybe not even the most important one if it's a stable condition. So that's why it's also good that we bring together today a lot of different disciplines and expertise in different diagnoses, because there are more similarities than differences. I think key questions that we have to ask ourselves are, okay, how do they develop and what are their actually needs? So I'm very into, okay, what do they actually need, instead of that we impose our ideas on them. And again, I mentioned the different diagnoses, and being the diagnosis only one of many. It could be developmental needs, physical illnesses, mental health issues, multi-morbidity, so a combination of mental and physical illness, often very hard for people to find services because, right, it's one or the other, and hard to bring it together. And then there are also other populations at risk and additional layers of complexity. Think of cultural background, or family situations, socio-economic determinants of health, and so forth. Another question is, and maybe also to look into and delve into the systematic reviews, is actually who are the people at risk, and how can we develop services tailored to those at risk? Because are we actually providing the full package to everyone in the same way, or are we tailoring it to their needs? And maybe some of them are doing quite well and don't need much of our support, where others are maybe dependent and need full support of others. And then there is the middle group that I think is the most interesting one, because there we can make a huge difference, because they have the potential to take charge of their own health and transition well. But if we don't support them well, they drop off. And I think we should focus on that group. So, and how can we then support them over the life course? So I mentioned the word complexity already a few times in my talk, and no surprise, this is my favorite cartoon, looking at the elephant in the room, and with all the different disciplines, we often see a part of the full picture, but it's hard to bring it together. We talk a lot about multidisciplinary or interdisciplinary work, but it's hard to do. So how can we actually do that better? I try to come up with something simple for today's talk, and always easy when you're in pediatrics to talk about the ABCs, easy to remember. There are many ABCs, of course, but in the context of transition, I think raising awareness is very important and continues to be important, even though Anna-Loes doesn't have to explain transition so much as she did 20 years ago. Still, there is work for us to do at the local level, so in our own clinic perhaps, or in our hospital or institution, or in our local network. Then at the national level, and I think that's where the guidelines come in. There's a huge benefit to having guidelines, not only for it can help us guide us to organize our services and doing it better, but also having a guideline in itself helps to raise awareness. And we've seen it here in the Netherlands that positioning a guideline really has helped. At the global level, I'm not sure yet what we do. But maybe we can think about it together over today and tomorrow. Building capacity is really building capacity in the person and in the family, I think, to help them meet their needs. And we are there to support them. There are different programs. We heard about the transition programs, so there are different elements to it, key ingredients. Some work maybe less so. What I would say, my summary always is, doing something is always better than nothing. And I know I'm speaking to the choir here. I know you are invested already, but there are so many other people who find transition really overwhelming. And we have to help them sort of making that first step and get into helping young people with transition. But we can also do better at the national level, and we have different countries. I would be very interested to learn what you are doing in your country in terms of coming together. Maybe there is a platform, and in Canada, and Fournier from Canada and Montreal will talk about the transition hub that we started in 2019 and has grown to become a community of practice and just learning from each other, coming together and not feeling that you have to do it all by yourself and not to reinvent the wheel. And if we have those platforms at a national level, maybe we can bring that together at a global level. Then there is the collaboration piece between the pediatric and the adult side of services, but also, of course, with the young people and the families themselves. That has to happen locally, because even if the principles are applied globally, and I think they do, I've been to a couple of places and we talked about transition programs. I think the principles, starting early, for example, and building capacity, they all apply. But you have to make it happen locally. So, and that's where the collaboration piece comes in. And the best sessions I had experience with was bringing together adult healthcare providers and pediatric providers together, and then learning that they even, although they work at the same institution, a hospital, they even didn't know each other, and making that connection and to start the conversation. Okay, how can we make sure that we develop a program for our own population at that institution, but also maybe in our network? And again, we can build that at the national level and the global level. And if you ask me, we shouldn't do that for each condition on its own, but really trying to bring together the different groups, at least at the sort of main group level, so developmental, mental, physical illnesses. But to me, again, I would say if we come together at the national and global level, we should go and go by the principles of equity and inclusion. So we talked about the knowledge and the gaps in our knowledge and how we can improve it. And that's why we are here together also to share our knowledge, what we have learned in our clinic with the posters and the different presentations. So we are really on the right side of the knowledge to action cycle, where there's the process of knowledge creation. You identify knowledge gaps and you do research, and at some point you have results and you will tell what the implications are. And in part, and that's needed, I'm a researcher too, but unfortunately it's a very slow incremental process. I see a few people of you nodding, and some of us, and including myself, maybe are old enough to say, yes, we have made progress over the last 20 years in the field, but I would love to see, we're still having that gap, because if you want to be here, what people really need and want and expect and can afford, then there is still that huge gap. And do we really get to that level if we just proceed this way? Or are there other pathways that we can change and make it a very steep curve? I want to challenge you with that, and I want to talk about it during the breaks. So how do we do it? I can ask the question because I'm standing here. I don't have to give you the answer. It's really us together finding out. One of the things I want to emphasize is, and again, one of the things that I think we are really, if we look into the future, is that there are way more determinants of health than health and healthcare. And here, the drivers of health are only in a part the condition and the makeup of your DNA and so forth. There are postal code, for example, contributes a lot because that is an indicator of maybe wealth and access to good food, for example. There is a huge factor in terms of behavior and all the interactions of above. Access to care explains only 9% of health in this example. And I have to, of course, acknowledge Sayana Kayat, who shared this slide with me kindly, because she actually developed this slide. But if you look where the resources go and where we live and where we do our work, that's most of it is in the medical care or medical care related setting. And I think that's where we have a challenge, or maybe could work on thinking, okay, can we move out of the hospital setting and go to the community setting? Can we influence other factors that are as important as the medical care? So that brings us to the other part of the knowledge to action cycle, which is on the left-hand side, and that is changing practice. Not surprisingly, that's part of the theme of our conference. So I think it requires rethinking of our approach in care and how we deliver care. And that brings me back to Neil Halvan in his model of life course health development. He discusses where we come from a very biomedical model, and here we are now in the biopsychosocial model. We do understand there's more than physical health, it's also psychological and social functioning that is important, and then interactions. That's very nicely displayed in the International Classification of Functioning, Disability and Health of the WHO. But where we should be going is more thinking at the population level and thinking not so much about illnesses, but about health and prevention for disturbed health and development, especially if we talk about children and young people growing up. So I want to bring that to this conference because I think we have opportunities at the local level. We can bring that to our discussions in our own setting, in our own clinic, and say, okay, yes, we are doing this work in our own setting, but what happens when the child and the family or the teenager and the family leaves the clinic or the young adult in terms of what do we do in terms of health development? We can just have those discussions at the national level. And if we don't do it as healthcare professionals, the government certainly will tell us to think about it. And in the Netherlands, there is het Integraal Zorgakkoord. I say it in Dutch. I cannot explain it, but it's really a big push to think at the regional networks and to address things outside of hospital. I think it's a good thing. I think, yes, there are challenges with that direction, but at the same time, it forces us to rethink our healthcare delivery model. And maybe also at the global level, because there are so many other countries that have less resources, and they are dealing with similar issues. I was thinking too about my own role and how I was trained as a medical doctor, as a medical student, and then as a trainee, and so forth. And for medical doctors, there's the ChemMeds competencies, but I think it applies to any healthcare provider or care provider even, that we all need more than one competency to do our work well. And so a lot of the training goes to being a professional, a scholar, a communicator, and a medical expert, and also integrating the different roles. But less of, at least my training, and maybe it has changed, I hope it does, but still, there are still challenges. Okay, how do we develop competencies as a collaborator? If you want to work with the community and want to sort of think of transitional services outside of hospital, how well are we doing that? And what sort of tools and skills do we have to make it work? Can we be a leader in that field? And I made it orange. I think there's a huge role for us to be a health advocate. Because if we don't do it, and I think we have the champions here in the room, because you came all from your home setting and left your busy clinics to talk about this important issue of healthcare transition. So when we go back, we have a huge role to explain it and tell others, okay, this is what needs to happen. And I would consider that as health advocacy. So this is, I reworded a little bit and made it personal. So I not only say I have to do it, I said we, the collective, we as health advocates can contribute our expertise and influence as we work with communities or patient populations to improve health and transitional care. We have to work with youth and young people and their families to determine and understand their needs, speak on their behalf when required, and support the mobilization of resources to effect change. That requires a mindset. So think of yourself in that role as not only being a professional, but also as a health advocate. And it also requires a set of skills. And there's not much literature. Actually, I was trying to look for, okay, how do you actually develop those skills? There is no, maybe there are some courses, but I think there is very little yet out there. But maybe we can help each other and think of, okay, skills that we can use to ensure access to care, because there's a huge issue, basically, if you talk about transition in terms of access. Navigating the healthcare system, of course, that comes up a lot, but also mobilizing resources in the community. What can we do? Addressing health inequities and influencing health policy and creating system change. Because a lot of the issues we're dealing with is a system that has been created in society. We have basically, it's not a problem of the young person and the family just turning 18. No, we have created a pediatric system, an adult healthcare system, and now the young person suddenly has a problem, right? So in Canada, we put out a call for action last year. It was done through the Adolescent Health Committee. Not so much new things, just reiterating what was out there already in guidelines and so forth. But it was really more that health advocacy piece, just having a document out there with a call to action and a position statement. Although the position statements themselves don't help much, there are position statements 20 years ago. I don't think that in itself helps, but again, little steps help. So that is one example of, I think, health advocacy. And the other thing is I start to get interested more and more also in policy. And one of my postdoctoral students, Linda Nguyen, has led a project within our research study, the Child Bright Radio Not Brain-Based Disabilities trial study, in which we have co-developed and co-designed an e-health intervention to support young people with disabilities for the transition. But basically the Patients and Family Advisory Committee told us you have to look at policy too, because yes, it's great to have an app, but our everyday life is dealing with issues beyond what you're doing in clinic. So they called for national standards to assess readiness to transition and see what is needed. So again, going back to assessment of their needs, to develop a federal framework to support an inclusive and equitable approach to transition. And if you think of equitability or equity, I think that's a great term to actually raise awareness and get people sort of thinking about, okay, how equitable is our care actually if we support some who are actually quite able to navigate the system themselves and others who are very much dependent. And then the last thing, and that's work for us to do also, that we need to evaluate our services and also to make it public so that we ensure transparency and make sure there is funding for those studies, especially with the lifespan approach, so long-term outcomes. I want to leave you with some questions to think about, not just to stimulate, to think, okay, what does advocacy mean to you as a person? Because it's in the end all about people and taking ownership. What does that mean in terms of making transition better? And also, as we are together, what can we collectively do? And as we are together, I was expecting most people in being the pediatric side, but luckily we have people on the adult side too. We can also learn from each other. We can think forward and say, okay, this is likely going to happen with the children in the future, but also learn from experiences in the adult setting. So that's the call for action. Less talk, more action, right, Annelies? To change practice. And I hope we can make transition better. Thank you so much for your attention.